And now the moment you've all been waiting for. So this is going to be nutrition support part 2. So this is parenteral nutrition. All right, so let's talk about parenteral nutrition. So again, previously we've spoken about enteral nutrition, which used the gut. Parenteral nutrition is intravenous administration of macronutrients, vitamins, minerals, and electrolytes directly into the bloodstream. And so you'll see a lot of different abbreviations in the patient's chart. It could be PN, TPN, CVN, CPN, IVH, HAL, PPN. And these are all different versions of essentially the same stuff. It really just kind of tells you, is it going into a big blood vessel or a little blood vessel? And so parenteral means something that is outside of the GI tract. So when do we use parenteral nutrition? So if we're unable to meet the nutritional needs from an oral diet or enteral nutrition, and for individuals with a GI tract that is non-functional, not accessible, or unsafe to use. Now, what you'll also see, though, is this may be used alongside an oral diet or enteral nutrition, which is you'll see patients will receive both. So again, we're trying to transition from one to the other, or because of tolerance, or because of a need for medication, etc. Right? We may be using or relying on one route for one usage, and then using the other route to provide support of those goals. So some sample conditions, for example, intractable vomiting, GI obstruction, impaired motility, abdominal trauma, injury, or infections. We talked about open abdomen in the previous lecture, and in which case, so we're saying that we're still unable to use the gut. Intolerance to enteral nutrition, a high output fistula, and so I have seen, for example, patients that had a hole in their GI tract. I could pour tube feed in, and I could watch tube feed pour back out of them, and the question was actually proposed, should we just, because it's gone through their system so quickly, do we actually just put it back in and just kind of run it through their body a second time? And we had ended up deciding not to, but that actually was on the table at one point. So short bowel syndrome or severe malabsorption and severe pancreatitis are other indicators where we may need to use parenteral nutrition. So contraindication. So contraindicated means it is a contrary indication or a reason not to do something. So a reason to not do parenteral nutrition is because their GI tract works. It's accessible and functional. A reason not to do parenteral nutrition is because we don't have access to their veins. A reason not to do parenteral nutrition is because we would only be using it less than 7 days. And so setting up that invasive IV line is actually more dangerous than not feeding the patient. And so a couple other reasons not to use parenteral nutrition. So a prognosis that does not warrant aggressive support, and the risk of parenteral nutrition outweigh the benefits. Now again, we saw that alphabet soup earlier of these different forms of parenteral nutrition. So we have two forms. We have essentially is that we have a TPN and a PPN. So PPN refers to peripheral parenteral nutrition. So this is going to go into the peripheral blood vessels. So a catheter is placed into a small peripheral vein, for example, in the hand or forearm. And so this is, for example, when you see IVs in medical shows and you see people with IVs in their arms or in their hands, that is PPN. Now, it could also just be IV fluids, but even then, if we put anything into the IV fluids, they're essentially becoming PPN. So this is large volumes of dilute nutrients through a peripheral vein. This can be used if we've established peripheral access, but this is only used short term because the amount of fluids that can be provided peripherally will not meet needs, as these small peripheral veins do not tolerate high osmolarity. So this is often used as a supplement to transition to enteral nutrition or PO, or if it's going to be short term. And so this can be used if parenteral nutrition is needed for 10 to 14 days. So again, if we're just doing IV fluids, somebody's got a busted jaw, we're working on getting you a blenderized diet, we just got to give you some sugar water and some salt water through your IV, and then we'll kind of transition you to enteral nutrition or PO. TPN is total parenteral nutrition, but again, you may also see CPN, which is central parenteral nutrition. So the catheter is placed in a central line for central access. This means it goes into your heart. So this allows for higher caloric concentration and greater osmolarity solution. And again, if we're going to be doing this longer than 14 days or longer than 2 weeks, right, then we would consider TPN in place of PPN. Now, the primary difference between parenteral nutrition and enteral nutrition is that one is using the GI tract, that is the enteral nutrition that we've already discussed, and one's going to be using the veins, which is the parenteral nutrition, which is the new concepts we're discussing. So feeding directly into the venous system, though, allows for the use of high osmolarity solutions regularly over 900. So remember, we said that the osmolarity of normal bodily fluids is about 280 to 300. Most formulas are about 600. A few of them are a little bit higher. This is pretty similar to most oral foods and beverages. But when we're going through a central line, right, we can go significantly more concentrated, more than 3 times concentrated normal bodily fluids and blood. So again, we've talked about peripheral access, so routine, peripheral, intravenous angiocatheter. And so this is what you've seen. Again, this is your standard IV that if you've ever gotten an IV at the doctor, you probably got a peripheral intravenous angiocatheter. This is the one that goes into your hand for, an inch or so. We also have the extended dwell catheter. So these require a larger vein, enough to advance the catheter 5 to 7 inches. And so these can remain at the original site for 3 to 6 weeks, and these may be midline or midclavicular, so you'll see them up on the chest, on the upper chest area. Now we have what's known as short-term central venous access. So a CVC, so a central venous catheter, is inserted through the skin, and CVCs are inserted into the subclavian, jugular, or femoral veins in the center of the body and reside in the superior vena cava or in the inferior vena cava. And so these have to be placed by a physician at the bedside. Now within the last, and I'm starting to feel a little bit old, probably within the last 30 years, I'm going to say within the last 20, but I've been a dietitian now for quite a while, we developed what's known as PICC lines. And so we have peripherally inserted central catheters. So these are actually inserted into the arm, so they go basically from your elbow into the subclavian vein, into the heart, into the vena cava. So somebody basically threads a piece of plastic from your elbow, up your arm, through your shoulder, across your chest, and then down into your heart. Now this can actually be done, this is a special set of training for nurses. So this can actually be done in the patient's room by a nurse, so this doesn't require a physician, and again, gets us that central access into the heart. Now, if this is going to be something that we're going to be concerned with or participating with long-term, we do have long-term central venous access, and so a couple different options. So we have tunneled catheters, which you guessed it, are tunneled under the skin during a surgical procedure. And so there's a couple different names. So for example, you've got your Hickman, Broviac, Groshong. The subtleties don't really matter to us as practitioners. The exact placement would be more of the surgical technique and how it's placed. But for us, right, once you have access, all that determines is either you have central access or you don't. We also have what's known as implantable ports. So these lie completely under the skin and decrease the risk for infection. So these are more difficult to access. So somebody has to basically go fishing, and you literally can feel the lump under your skin. So these are placed surgically, but these are useful in patients with body image concerns, but then also in very, very long-term use. So for example, in cancer treatments, where we're expecting the patient to have to be using this access multiple times per week for months on end, again, right, this is something that would be under the skin. You kind of have to go fishing for it, but then they can access it, right? And then after you're done with treatment, right, there's nothing sticking out of your body that could get infected, contaminated, etc. Now, again, we said these can be placed at bedside, but all catheters have radiologic confirmation, so that's to make sure that they're actually where they're supposed to be, or when they're placed, right, we're actually taking a picture as we thread them through the blood vessels. Now, catheters may be single, double, or triple lumen. So basically, they look like a Y, or they look like they have 3 points of entry. So these can actually be used to provide medication, fluids, and nutrients. So especially, for example, a patient who's receiving chemotherapy, they may get drugs through one port. They may get then through the second lumen, right, or the second branch, they may be receiving hydration. And through the third branch, they may be receiving some other medication, anti-nausea medication, etc. So short-term catheters are usually changed every few days to prevent the risk of infection. So again, the problem is that the plastic has a tendency, and this is unavoidable, is that things stick to the plastic, and kind of like a moldy shower curtain, right? Bacteria kind of start to grow on the catheter. So again, that's why there's a risk of placing them, right? We don't just do these willy-nilly. And so then what we need to do is we need to change them fairly frequently, unless they have, so there are some that have special coatings to prevent bacteria growth, etc. And so here you can see some examples. So you have in the middle section, you have a single, a double, and a triple lumen. So again, you see a single, a Y, and then what looks like a W. So you have three different ports, which again allows for three different medications. Now here you can see on the left photo, you can see this clavicular line that goes right, in essence, it's going through that large blood vessel right at the top of the chest and then down into the heart, into the superior vena cava. And so here you can see some of the different placements. So again, you have this mid-clavicular line on the right of on the patient's anatomical right. You can see, so from the bag into the mid-clavicular line. You can also see this PICC line though, which is inserted all the way down at the elbow on the left side of the patient. So if you were the patient, it would be the left side, the anatomical left. It's inserted at the elbow, fed up through the shoulder, across the chest, and then down into the heart. And again, so you can just see some further examples. So for example, this tunneled catheter would still be accessing the same blood vessels. It's just large portions of it are under the skin and not sticking out. So let's talk about what we can put in these catheters. So these different solutions are mixed or compounded in a hospital pharmacy in a clean room using a hood. This is like a chemist hood, which is a sterile environment. So you don't see this much anymore. So if you go to certain pharmacies, you can get certain medications, and what that means is they've been compounded. And so, for example, that means a lot of times, and there's a lot of jokes about this, and it's a little more complicated than that, obviously, but there's a lot of jokes that pharmacists don't do a whole lot other than count pills. Well, especially in a modern medical system and in modern pharmacies, that's what they want you to do, is verify medications that have already been made. So they want you to verify dosing, etc. Make sure there's no interactions. Basically, make sure that if the patient doesn't take 2 pills, something goes terribly wrong. But in the old days, right, and still today, certain medications have to be what's known as compounded, which is they're unstable. Usually. So what happens is they have to be mixed together, and that's when you have to take them home, and they say keep them in the fridge, right? Because they don't last forever. Whereas, of course, your traditional tablets are good for years and years and years. Well, the same thing, right? These are compounded, or these are actually made on site from a stock concentration, right? Like a true chemist, they're sitting there with stock solutions going 3 drops of this, 4 drops of that, a whole bunch of water, shake, 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 put it in his bag, run it through the, so on and so forth. And this is done under your chemist hood, right? So this has the air vents that suck everything down to make sure that there's no germs floating in the air. Everything's mixed, right? Because remember, this is being pumped directly into someone's blood vessels. So this has to be sterile, no germs, nada. So all the nutrients needed for 24 hours are put into one bag. So this isn't like enteral where you have to like keep refilling it all day. This is a one-stop shop. I throw it all in the bag, seal the bag, stick it in your arm, and we're good for a day. So these are made to order on a daily basis, though, because again, this is literally how you grow bacteria, right? Think about this. This is a nice liquid solution full of sugar and proteins. I mean, this is the perfect food for bacteria. So we have to make this fresh every day, right? And then make sure that the patients are getting it, and then we change it out every day to prevent and reduce the risk of sepsis. So we have the 2-in-1 system, which will provide sugar and protein in one bag and lipids in a separate bag. The 3-in-1 system is sugar, protein or amino acids, and lipids all combined into a single bag, and this is known as TNA, or total nutrient administration. So here you can see a compounder. So these are stock solutions. So you'll see in the actual machine, you'll see all those different containers, and then they all lead to a bag. And so what happens is that they go, I need 100 mils of this, 50 mils of that, 300 mils of this, 200 mils of that, 50 mils of this, and it all leads to one bag, and then that bag is what will be provided to the patient. Now this is actually pretty rare these days, though. So the only time you're going to see a compounder is basically if you have your larger facilities, your Tampa Generals, your large Bay Cares, your large Orlando Regional Healths, right, where they need custom formulas. Your smaller community hospitals can order pre-mixed bags where they're not made on site. So they're made off-site, basically shipped to the facility, and then used fairly quickly. Now here you can see a 2-in-1. Now it is bright yellow, right? This is the famous banana bag color, but these are actually going beyond the banana bag. So this would actually have in it glucose, amino acids, and vitamins. So it is bright yellow because of the vitamins. If there are no vitamins, it will be crystal clear like water. Next to it, so this is a 2-in-1. So you have 2 nutrients, glucose and proteins, in the yellow bag. On the right, next to it in the white bag, are the lipids. And so that is a 2-in-1. You have 2 nutrients in one bag and a third nutrient in a separate bag. Here you can see a 3-in-1, so you'll see it's a larger bag, where in essence those separate bags from the previous slide have now been mixed together into one super concoction. Now, it seems right like the 3-in-1 would be easier, just mix it all up, but both approaches have their pros and cons. So the advantages of the 2-in-1 solution, so lipids are added separately in a 100 milliliter, 250 milliliter, or 500 milliliter sized container, which provides greater flexibility in the amount of dextrose and amino acids that can be given. Now, the 2-in-1 solution itself, which consists of the glucose and the amino acids, is clear, and therefore any precipitation can be observed. And so we'll talk about my favorite chemistry joke in about two slides. Two slides. So the disadvantages, though, is there's a need for the additional administration set for the lipid infusion. So this requires separate IV tubing and a separate pump, unless you have one of those. There's several pumps that can pump multiple solutions at the same time. A 3-in-1 solution. So the advantages is there's a single administration set. So I just plug the bag in, turn the pump on, and walk away. This saves nursing time. It's cheaper. And the disadvantages, though, is that the opaque solution, which obscures precipitate and increases the risk of particulates being infused into the patient. So my favorite chemistry joke is, if you are not part of the solution, you are part of the precipitate. And so what happens is with a precipitate is that you mix 2 liquids together and they actually will grow crystals, or they will grow, right, something will come out of solution. So the problem is that if I put the wrong concentration of sugar and calcium and sodium, so I can actually end up growing crystals in the bag. Well, hopefully nobody needs an MD to figure out that pumping crystals into someone's blood vessels is really, really bad for them. When the solution is milky looking, I can't actually see that, and so if there are any precipitates or crystals in there, I won't see them until it's too late and they've gone into the patient's body. And the other problem is the addition of lipid into the solution limits the electrolytes and the final concentration of amino acids that can be used in the solution. Now let's talk about, so we know that obviously we're going to have to provide our patient with carbs, fats, and proteins. Let's talk about how we actually do that. So for protein, right, this is included in parenteral nutrition in the form of crystalline amino acids in amounts consistent with the World Health Organization. And so these are literally, right, the individual amino acids are all individually added in different concentrations. Now, the overall concentration of the solution is somewhere between 3.5% to 20%. Lower concentrations, around 3.5% to 5.5%, are used for peripheral parenteral nutrition, and the higher concentrations, 8.5%, 10, 11, 15, and 20, are going to require central administration. Now, like all other proteins, these amino acids have 4 calories per gram, and approximately 15 to 20% of the patient's total calorie intake should be from protein, or, right, if we're doing it based off of a grams per kilogram need. Now, I gave you these worksheets ahead of time to look at and practice on, so again, you're not expected to know how to do them, but if you are interested. So, for example, a 10% amino acid solution, right, so is 100 grams of protein per 1,000 milliliters. So this is 100 divided by 1,000 is 10%, and that's it. That's the whole math. And that's what's so nice is that these are true solutions using the metric system. So 10%, right? 10% of 1,000 is 100. That's 100 grams. 5%, right, of 1,000 would be 50 grams, right? And that's it. And that's all you have to do for protein. Now here you can see, so these are some different brands. So again, these are not compounded. These are not made on site. These are ordered, right, from, we'll talk about this some more in our lecture. But these are going to be ordered from specific medical supply companies that come pre-made, and they're going to have certain concentrations. So you can see, for example, these have different concentrations. For example, the liver formula hepatamine is 8% protein. You can see, for example, let's see another good one. Nephramine is 5.4% protein. Let's see, your standard aminosin or Clinomix, which is the brand that we use at my hospital, comes in 3.5%, 4.25%, 5%, 7%, 8%, 8.5%, and 10%. Again, depending on your patient's needs. So carbohydrates. So protein stayed the same at 4 calories per gram, but carbohydrates are a little bit different. So we're going to give people pure dextrose, C6H12O6, just pure glucose, no double bonds, no long chain starches, right? I'm pumping sugar, the absolute most simple unit of sugar, dextrose, which matches your blood sugar into your body. This only has 3.4 calories per gram. So there's a minimum of 1 milligram per kilogram per minute to spare protein from being used for energy. So during our lecture, when we do our interaction on Zoom, I will show you there is a nice calculator to explain this to you. Giving people too much dextrose can lead to high blood sugar, fatty liver, and increased ventilation, right? So we know that a high carbohydrate diet causes increased CO2 production. So the maximum rate we recommend is 4 to 5 milligrams per kilogram per minute in adults. You can actually see that number doubled in pediatric patients, but that's the exception. In adults, it is 4 to 5 milligrams per kilogram per minute. Again, carbohydrates come in a stock concentrations, typically of 5, 10, and then 50 or 70% to be compounded. And again, just like our protein, a 10% solution, so 10% of 1,000 is 100. So 10% dextrose is 100 grams in 1,000 milliliters. And most patients, right, get a standard initial dose of 100 to 150 grams of carbohydrate. All right, so we'll move into our next substrate. So we'll take a look at lipids. So the lipids are typically an emulsion of soybean or safflower oil. So this helps provide the essential fatty acids and vitamin K, with 2 to 4% of our total calories coming from linoleic acid to prevent essential fatty acid deficiency. And so lipid formulations come in 10, 20, or 30% concentration. So the 10% lipids contain 1.1 calories per milliliter. The 20% lipids are 2 calories per milliliter, and the 30% lipids are 3 calories per milliliter. Now, to make this even more confusing, these lipid emulsions contain glycerol, and so the glycerol serves as an emulsifier. So glycerol does contain calories, and so these actually contain additional calories. So instead, right, fats normally contain 9 calories per gram. When we're looking at parenteral nutrition, lipids will have 10 calories per gram. Now, these are contraindicated if there's an egg allergy or the patient has hypertriglyceridemia, so if they have high levels of fat in the blood already. And so then what we have to do is we may do this less frequently, or again, if it's an egg allergy, then we may have to find an alternative. So again, the big concern, right, being an allergic reaction. Now, we've talked about this previously, but just as a review, so propofol, which is a lipid-based sedative used in the critical care setting, does contain 1.1 calories per milliliter. And so we need to be sure to include the calories from the propofol along with, right, the parenteral nutrition to get our total calories for the day. So looking at the electrolytes, so we use the DRI standards as a benchmark, but they can be individualized and adapted based on the patient needs. So again, based on body weight, any electrolyte deficiencies, ongoing losses, or changes in organ function, for example, the renal system. So these are the most difficult portion to calculate, and serum electrolytes will be drawn daily to monitor and adjust. So in essence, right, we're playing this game. We're always a day behind, but what we do is we check the patient's blood the next day, a little bit of this, a little bit of that, run it, check it the next day, continue to tweak it. But that's what we're always doing, is we're always drawing blood work that morning at about 4 or 5 a.m. and then adjusting, right, the day's electrolytes. So vitamins and minerals. So commercial multivitamin infusions are used, and these can be given at a lower amount than the DRI, as again, we're putting these directly into the bloodstream. So, for example, we know that with many micronutrients, right, is that they're not well absorbed, but that's not the case because we're not going through the GI tract. We don't have to worry about absorption, right? We're going directly into the blood. And so for long-term parental nutrition patients, we may actually provide micronutrients every other day to avoid toxicity. And so what we've learned over several decades of providing parenteral nutrition is the need for trace minerals. So these are usually on a standard protocol, and the commercial preparations usually contain 4, 5, 6, or 7 trace elements. Again, there's not a standard, it's more of a what's worked in the past, what's available. And these typically include zinc, copper, chromium, and manganese, while some newer products also include selenium, iodide, and molybdenum. And so here we can see, so the adult daily requirements for parenteral vitamins. And so again, what you're going to notice is that these likely appear to be much smaller units than normal. And again, realize that we're not worried about digestion and absorption because we're going to get 100% right of these micronutrients because we are using an IV route. And here we can see, so the daily trace element additions. So again, we can see and look at, for our specific trace elements, the standard intake. So medications. So additionally, in addition to the nutrients, we can also provide medications through this route. So this is things like insulin, albumin, heparin, famotidine, and others, right, can be provided IV. Now fluid, right, we'll talk about the total fluid intake. So prescriptions are typically between 1.5 to 3 liters, while keeping a close eye on fluid status, and again, accounting for any other sources, including other IV medications or blood products. So what happens is we basically figure out your fluid needs for the day, figure out your nutrient needs for the day, dissolve it all into the bag, and just run it. And that's just kind of all you get, and it provides you everything, right? We can put medication, we can put nutrients, we can put the fluids all in one super product. So the way this is provided is so similar to the enteral nutrition. We have a continuous rate. Now this is usually initiated at a half of the goal rate and increased over 2 to 3 days. And on the flip side, we cannot just abruptly turn it off. So again, what happens is we are pumping nutrients and specifically glucose into your body. This causes an upregulation of the pancreas to produce additional insulin. If I were to suddenly turn off your nutrition, what would happen is that your pancreas would not stop producing insulin. And so you would have, in essence, too much insulin, and you would develop rebound hypoglycemia. So we cannot turn off parenteral nutrition abruptly. It has to be slowly turned off. The other option that we may provide is cyclical parenteral nutrition. And so this can be 8 to 12 hours at a time. Again, typically given overnight, similar to our enteral nutrition for increased mobility during daytime. It also gives the liver a break. So one of the biggest long-term complications is liver damage. So a cyclical infusion does give the liver some break from processing nutrients, but overnight this may require a higher rate of infusion. And so looking at how this is actually done, so we need to develop a prescription by, again, first determining a dosing weight, which is how much the patient weighs, and we have to agree with this in the medical record. From there, we'll determine a calorie goal that's adjusted for activity and injury. And then here we're going to start with protein, and so, or I should say protein needs. And so here when we take a look at, so again, we're going to use our lipids first as, again, part of our total calories. Then we have to meet our protein goals, and then the remaining calories will come from carbohydrates in the form of dextrose. And again, not that we do a lot of tinkering with it, but just that we need to review the electrolytes and vitamins and minerals, and then prepare a final parenteral nutrition prescription. So here you can see, and you can zoom in on this, but you can actually see an example of an order set where, again, it has the route, the rate and volume, and then the specified percentages of the macronutrients, and then as well as the micronutrients. Now I can tell you as a dietitian and in my practice, I've never actually adjusted micronutrients. It's incredibly difficult and very precise. There's not a lot of room for error. And so a lot of times the pharmacists are doing this with a computer system to assist them in making the proper decisions. Here you can see another sample order form where, again, you can see there's a large option for controlling the micronutrients, which, again, I would encourage you not to do without some advanced and additional training. So how do we actually provide the parenteral nutrition? So Aspen recommends a standardized protocol for the delivery of parenteral nutrition, and a standard order form should be used to ensure that basic nutrition needs are being met and that errors are minimized. Now, this is a little bit different. So providing an IV, right, is technically a physician. It's a medical order. So again, what can happen is the doctor may defer to you, but at the end of the day, the doctor actually has to sign off and approve the treatment. So just understand, right, there's going to be several sets of eyes on this. You're going to look at this. The pharmacist is going to look at this. The doctor is going to look at this and then sign off and say, yep, it all looks good to me. Because again, what we want to do is we want to make sure there's as few errors as possible and minimize the chance that that happens. So we're going to have intense monitoring in the first few days. So again, specifically looking at electrolytes and micronutrients. And so standard monitoring includes looking at I's and O's, so how much fluid is going in and coming out, a concern for hyperglycemia and monitoring of blood glucose, and then looking at our daily measurements for our electrolytes. So again, our comprehensive metabolic panel of BUN, creatinine, magnesium, and phosphorus, and baseline triglycerides to again determine if it's appropriate to provide this patient with lipids. So again, if they're having hypertriglyceridemia, they may be given very infrequently. Otherwise, right, we can use them approximately, we usually use them about every other day or about 3 times per week. So complications, again, are similar to enteral nutrition. So the GI complications, so because we are not using the GI tract, there's a risk of cholestasis, atrophied intestinal cells with increased permeability. So again, that leaky gut syndrome. So again, what you may see is they may recommend that trickle feed or, for example, 5 milliliters an hour of an enteral nutrition to again help protect the gut while the patient receives most of their nutrition from parenteral nutrition. Now you're asking, in essence, the liver to process nutrients 24 hours a day. So what you may see is liver enzymes go up, which means that the liver is not tolerating the constant infusion of parenteral nutrition. As there was a few mentions during the lecture previously, so there's a risk of infection because, again, you do have an IV placed for long periods of time. Electrolyte imbalances, high blood sugar, high triglycerides, over and under feeding, and again, refeeding syndrome, which is why we are so closely monitoring the electrolytes when we first start parenteral nutrition. So again, who actually writes the orders? So again, what you may see, and so the order has to be signed off by a physician, but depending on, right, that in your facility, that it may be really being monitored by a physician's assistant, the pharmacist, or the dietitian, with the physician just in essence providing a signature on the blank check. I strongly encourage you to build that strong relationship with the physician and the pharmacist. So again, having multiple sets of eyes on this, making sure that things are done consistently and safely. And so again, like I said, I would not want to adjust micronutrients without some advanced training. The pharmacists do have software to ensure that there's no compatibility issues. And so some facilities do have nutrition support teams where in essence any patient that's receiving tube feed or TPN is going to be discussed and reviewed and then can be adjusted as a team approach. So again, transitional feed. So our goal is to always use the GI tract whenever possible. So a transitional feed, though, is how we go from parenteral nutrition to some other type of feeding. And multiple types of feeding may be used simultaneously. Again, so initial oral diets might be better tolerated if they're lactose-free, low-fat, and low in simple carbs. So if we're trying to let the gut heal and then go from parenteral nutrition to oral, right, we want a well-tolerated, very bland diet initially. Now you'll still see this medical order written, even though it shouldn't be, which is advanced diet as tolerated. And so that's frowned upon, not conceptually, but the way it's written, which is it needs to be spelled out, which is if the patient tolerates clears, advance to full liquids for 2 meals. If tolerated with no signs of blank, 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 advance to regular, right? So it has to be more specified than just advanced diet as tolerated, which is really just passing the buck and telling the nurse, do whatever you feel like. And so they have actually discouraged that, and so Jacob will get you in trouble. So you should not see doctors writing advanced diet as tolerated. There should be more specificity in current charts. Occasionally you'll still see, though, people will write it and then someone has to come and correct the physician and get them to make a change to the medical chart. So going from parenteral nutrition to enteral nutrition. So we'd want to initiate the enteral nutrition at a low rate to establish tolerance in the GI tract. We may use a pre-digested formula, which again is going to improve tolerance. And then increasing enteral nutrition by 25 to 30 milliliter increments every 8 to 24 hours while slowly reducing parenteral nutrition. So again, you'll slowly turn one up while turning the other one down. And once the patient is meeting 75% of their needs from the enteral nutrition, then we can discontinue the parenteral nutrition. And this may take 2 to 3 days or more. And again, this lines up very well with the fact that we do not want to turn off parenteral nutrition abruptly with our concerns of rebound hypoglycemia. So this helps manage that kind of with a built-in system. If we want to go from parenteral nutrition to oral intake, again, we want to decrease parenteral nutrition as oral intake increases. And once meeting 75% of estimated needs via the oral diet, we can discontinue the parenteral nutrition. Now, what we may do, though, is we should count calories, because the problem is, so this is 75% of estimated needs, not 75% of the tray. So again, my biggest concern is when patients order black coffee and toast, they drink their coffee, they eat their toast, and the nurse says, oh, they ate all of their breakfast tray. Yes, they did, all 75 calories of it. And instead, I need to meet 75% of your needs, not just are you actually eating your tray. So just be careful and maybe use a calorie count if appropriate. And if we're not able to completely discontinue the parenteral nutrition, then we may be able to use it less than 7 days a week, or do cyclical feeds right and only provide it at night while allowing the patient freedom to eat and move around during the day. Now, kind of as a built-in to this concept of this nutrition support, so we've talked previously about advanced directives. So these are legal documents used by residents to state their preferences in regards to medical care in the instance of a terminal diagnosis, which includes nutrition support. So again, this whole family of enteral and parenteral nutrition. So nutrition support may be beneficial in older adults, but it may have no advantage for some older adults and may prolong suffering in some cases. So it's very important that, again, when we look at artificial nutrition, how specific someone's advanced directives are. Does it include enteral and parenteral? Does it only allow for enteral? Does it only allow for enteral for a short period of time? So on and so forth. Now we can provide, so enteral nutrition and parenteral nutrition can both be provided in the home environment. And so it's actually, so it's a durable medical equipment supplier, a durable medical equipment company. And so what they do is they are, in essence, the people that lease the pumps. And then what happens is that they still have a dietitian on staff who is going to communicate with the medical professional as well as the patient. So again, we're looking at how these supplies are going to be shipped to the house. Basically, you have the right amount of tubing, then setting up, so when is the nurse going to come, how often is it going to be changed out, et cetera, et cetera. That's all done on a certain schedule, and so these companies, these home infusion companies or these durable medical equipment providers do have RDs on staff to help resolve and these issues and kind of answer questions. All right, so we'll take a look at practice questions. So patients who have permanent conditions that leave them with inadequate gastrointestinal function to maintain nutrition status, so without adequate gut function, right? And so here we're going to be looking at, is central parenteral, right, or that TPN, that total parenteral nutrition, which is going to be our long-term providing all of our nutrients. So that's answer choice B, central parenteral nutrition. Patients receiving parenteral nutrition need infusions of lipid emulsion too. And so we said, remember this, so this is, why do we have to provide them with lipid emulsions? Can't we just give people protein and carbs? And so we want to, this is answer choice A, prevent essential fatty acid deficiency. Remember we said about 2 to 4% of total calories should come from those essential fatty acids. And so I just always appreciate this meme. So I don't know if any of you have seen this, but it was very popular several years ago. And so once you actually notice that what I actually do is actually the tube feeding regimen. And so in this case, it's actually enteral nutrition, but this is kind of that high level skill set when you're in the hospital of actually having to customize that enteral and parenteral nutrition to meet patient needs, in addition to medications, looking at the doctor's wishes, how soon we can wean this, looking at liver health, looking at blood glucose. So this is really when you're having to use a combination of all of your skills to make sure that patients are getting and receiving the nutrients they need safely. So there are the references. So like I said, tomorrow we will review the math. So you can actually see the math in the lecture where it just talks about the calories. but we're going to actually go through the process of how to do that step by step tomorrow during our Zoom session. So please post your questions in the discussion board, and if you have any other questions, please feel free to email me.